And today we'll talk about intestine and intestinal disorders. Okay, we'll start from small intestine. You know, of course, that we have two parts of intestine, small intestine and large intestine, or small bowel and large bowel. First of all, let's talk about small intestine. Small intestine extends from the duodenum to the ileocecal valve. It's approximately 6 meters in length. The upper 40% the jejunum and remainder the ileum. Its surface area is enormously increased by mucosal folds. In addition, the mucosa has numerous finger-like projections called villi, and the surface area is further increased by microvilli. The crypts open into the lumen between the villi, and the epithelial cells are formed at the bottom of these crypts and migrate to the tops of villi from where they are shed. This process takes 3-4 days. Okay, this is picture from anatomy or histology. Again, all surface covered by villi. Villi has microvilli, and the main idea of this structure is to increase surface for digestion and absorption. So, functions of the small intestine. Of course, number one function, this is digestion and absorption. Continuous cell renewal and cell death. So, again, I told you every 3-4 days we have completely new surface of our small intestine, or mucosal layer. Defense against antigen entry, and this defense has structural, immunologic, and other types of protection. Neuroendocrine peptide production and motor function. Transit of nutritions. But again, the most important two functions, digestion, absorption, and transit, motor function. The epithelial cells form a physical barrier permeable to ions, small molecules, and macromolecules. The small intestine is concerned with the digestion and absorption of nutrients, salt and water. Digestive enzymes, protease, disaccharidase, produced by intestinal cells, and nutrients can be absorbed throughout the small intestine. Vitamin B12 and bile acids have specific receptors in the terminal ileum. This is very important to understand. Again, I told you, 6 meters length of small intestine. And all parts of small intestine can digest and absorb everything. That's why even damage of rather big parts of small intestine rarely lead to serious events, outcomes. But for B12 vitamin and bile salts, they can be absorbed only in terminal part of small intestine, terminal ileum. And if we have local damage of this part of small intestine, it may cause a problem with B12 vitamin, B12 deficiency, and B12 deficiency anemia, and bile salts. So let's talk about signs, presenting features of small bowel diseases. Now, first of all, this is diarrhea. This is a common feature of small bowel disease, but approximately 10-20% of patients will have no diarrhea or any other gastrointestinal symptoms. So, one of the most common signs, this is diarrhea. Second, this is abdominal pain and discomfort. Abdominal distension can cause discomfort and flatulence. The pain has no specific character or periodicity and is not usually severe. Steatorrhea, this is presence of fat in feces, occasionally present. Weight loss. Weight loss is due to anorexia that invariably accompanies small bowel disease. Also, malabsorption occurs. So again, problems with digestion and absorption may cause weight loss and malabsorption signs. For example, deficiency in vitamins and microelements. Nutritional deficiencies. Deficiencies of iron, B12, folate, or all of these leading to anemia are the only common deficiencies. Occasionally, malabsorption of other vitamins or minerals occurs, causing bruising, for example, in case of vitamin K deficiency, tetany, calcium deficiency, osteomalacia, vitamin D deficiency, or stomatitis, sore tongue and aphthous ulceration, multiple vitamin deficiencies. Now, ankle edema may be seen in partially nutritional and partially due to intestinal loss of albumin, so-called hyperproteinemic edema. Uh, Other signs, few physical signs, so what we can find on examination. Few and non-specific. If present, they are associated with anemia and the nutritional deficiencies. Abdominal examinations is often normal, but sometimes distension, rarely hepatomegaly or an abnormal mass are found, for example, due to tumor. In the severely ill patients, gross malnutrition with muscle wasting is seen. Neuropathy, not always due to B12 deficiency, can be present too. Steatorrhea. Stool, pale, bulky, offensive, contain fat more than 17 millimoles per day. Float in the lavatory pan because of their increased air content. Difficult to flush away. So this is sign of presence of fat in feces. Steatorrhea. So, investigation of small bowel disease. You know, small bowel difficult to reach for examination. For example, for stomach examination, we have fibrogastroduodenoscopy. To examine large bowel, we have colonoscopy. But how to reach small intestine? No, first of all, small bowel follow through. This X-ray examination, and this detects gross anatomical defects such as diverticula, stricturus, Crohn disease. Dilatation of the bowel and change fold pattern may suggest malabsorption, but as these are not specific findings, the diagnosis should be based on this, shouldn't be based on this alone. Fat malabsorption. Now, fat malabsorption, how to detect? The confirmation of the presence of steatorrhea is only occasionally necessary. The fat content of stool is measured using a 3-day collection of feces with the patient on a diet containing 100 grams of fat daily. And normal feces fat excretion is less than 17 millimoles, or 6 grams per day. 6 grams per day. If more, we talk about steatorrhea. Now let's talk about colon and rectum, or large bowel. So, large intestine starts at the cecum, on the posterior medial wall of which is the appendix. The colon is made up of ascending, transverse, descending, sigmoid parts which join the rectum at the rectosigmoid junction. The muscle wall consists of an inner circular layer and an outer longitudinal layer. The outer layer is incomplete, coming together to form the tinea coli, which produce the haustral pattern seen in the normal colon, haustration we call. The mucosa of the colon is lined with epithelial cells with crypts, but not villi, so the surface is flat. This is difference between small intestine and large intestine. In small intestine we have villi or finger-like, and in large bowel we have smooth surface. Surface is flat. The main role of the colon are the absorption of water and electrolytes and the propulsion of content from the cecum to the anorectal region. Approximately 1.5 to 2 liters of fluid pass the ileocecal valve each day. Absorption is stimulated by short-chain fatty acids, which are produced predominantly in the right colon by the anaerobic metabolism of dietary fiber by bacterial polysaccharides enzyme system. So a long story, but actually you should know that our large bowel contains a lot of microbes. We carry about 1.5 kilos of microbes in our colon. And all these colon are benign for us, vice versa. What they do, for example, they stimulate normal function of large bowel. Again, everybody knows that you should eat fibers for normal function of large bowel. But why we should eat fibers? Again, these fibers cannot be digested by our own enzymes, and they reach large bowel. And in large bowel, these fibers are digested by our microbes with releasing of short-chain fatty acids, and they force our large bowel to contract, to propulse. So that's why we have some symbiosis between our germs and our body for normal functioning of our large bowel. So now what you can see that totally in our intestine we have up to 9 liters of water. 9 liters of water, because actually you see this is we drink about 1.5 liters of water, then gastrointestinal secretion is about 7.5 liters, but finally output is only 150 grams of feces. Again, the rest is reabsorbed in our intestine, including large bowel. Mixing of colonic contents, which aids this reaction and absorption, is achieved as a consequence of non-propagative segment muscular contractions. Propulsion is achieved by the action of high-amplitude propagative colonic contractions, and normal colonic transit time is 24-48 hours with normal stool weights of up to 250 grams per day. So what we're talking about? It needs about 1 or 2 days to propulse this feces through the large bowel, and it's normal. Okay, let's talk about signs. Constipation. Constipation is a symptom and thus a term that people use to express sensations of or bodily functions that they perceive to be abnormal. The commonest definition of constipation are infrequent passage of stools, less than 2 per week, straining more than 25% of time during defecation, passage of hard stools, and incomplete evacuation. According to this definition, constipation affects more than 1 in 5 of the population. So again, constipation is not only rare defecations, but if patient has hard stool, or if patient should straining during defecation, it's also considered as constipation. So causes of constipation, a lot of. It may be general, even like a pregnancy, inadequate fiber intake, immobility. It may be endocrine metabolic. Now remember about hypothyroidism, low production of thyroid hormones. It may be functional, for example, due to irritable bowel syndrome. It may be some drugs, for example, opiates or antidepressants. They can induce constipation. It may be neurological, for example, due to lesion of spinal cord. It may be psychological due to depression, for example. Or it may be gastrointestinal disorders which lead to constipation. For example, colonic disease, rectum, or some other disorders. So again, in case of constipation, in most of cases we deal with causes which deal nothing with gastrointestinal problem. And among gastrointestinal problems, number 1, this is so-called irritable bowel syndrome. This is functional, not actually functional disease. But sometimes we have obstructive constipation due to some changes in the structure of patient's large bowel. Many symptoms attributed by patients to constipation and include headaches, malaise, nausea, bad taste in mouth. Other symptoms include abdominal bloating or discomfort, as well as local and perianal pain. There are broadly 2 clinical types of constipation. The slow transit form, in which patients rarely experience a call to stool, and obstructive form, in which patients experience a call to stool, but because of coexisting organic and functional anorectal diseases are not able to evacuate properly. So, slow transit constipation. The severity of slow transit constipation can be assessed by undertaking a simple abdominal X-ray to show constipation, and in more problematic cases by undertaking marker studies of colonic transit. Idea of these marker studies: patients should take special capsules containing 21 radial upper Q shapes and swallow on days 1, 2, and 3. And abdominal X-rays obtained 120 hours after ingestion of the first capsule, and each capsule contains shapes of different configuration, and the presence of more than 4 shapes from the first capsule, 6 from second, and 12 from third denotes moderate to severe slow transit. So what you can see here, this is shapes. This is shapes. Idea, we just try to understand how often these shapes patients swallow in special capsule pass through. And based on this, we can find, I can say, lazy colon, when just propulsion, very slow propulsion, usually due to some functional disorders. Obstructive constipation. Common cause of obstructive disorders of defecation includes the presence of an anterior rectocele, whereby weakness of the rectovaginal septum results in protuberance of the anterior wall of the rectum with trapping of stool if the diameter is more than 3 centimeters. The obstructive disorders of defecation can often be characterized by performing evacuation proctography. So again, this is a picture of rectocele. You see, this is rectum, this is vagina, this is rectovagina septum, and what happened? We have trapping of feces in so-called rectocele. No, this is one of possible causes for constipation, obstructive constipation. Diarrhea. Diarrhea is a common clinical problem. And there is no uniformly accepted definition of diarrhea. No liquid and frequent feces. Everyone knows what is diarrhea from this point of view. Now, organic causes, stool weights more than 250 grams per day have to be distinguished from functional causes. And in the first step, in the assessment of the history. So first, what we should understand, this is functional or organic. Organic means some damage of intestine or other organs. Functional, no damage, this is just problems with functioning. So sudden onset of bowel frequency associated with crampy abdominal pains and fever will point to an infective cause. Bowel frequencies with loose blood-stained stools, inflammatory belly to an inflammatory basis, and the passage of pale, offensive stools that float, often accompanied by loss of appetite and weight loss, to steatorrhea. Nocturnal bowel frequency and urgency usually points to an organic cause. So if patient wake up at night to defecate due to diarrhea, this is organic, because it's functional. Usually it's never happened at night when patient sleeping. Passage of frequent small volume stools often formed points to a functional cause. You see a lot of possible causes for diarrhea. It may be infective causes, different bacteria like Salmonella, Shigella, and other viruses like rotaviruses, for example. It may be non-infecting diarrhea. This is inflammatory bowel disease. This is diverticular disease and other disorders. It may be endocrine disorders, for example, pyrotoxicosis. It may be functional diarrhea due to other reasons. So there are different types of diarrhea due to different mechanisms of diarrhea. We have osmotic diarrhea, we have secretory diarrhea, we have inflammatory diarrhea, we have abnormal motility. So osmotic, secretory, inflammatory, and abnormal motility. So osmotic diarrhea. The gut mucosa acts as a semi-permeable membrane, and fluid enters the bowel if there are large quantities of non-absorbed hypertonic substances in the lumen. And this occurs because, for example, patient has ingested a non-absorbable substances. For example, purgatives such as magnesium sulfate. So if someone take magnesium sulfate, it causes diarrhea because due to osmosis law, water enter intestine and evacuate it with feces. As a result, we have actually osmotic diarrhea. And the patient has generalized other reasons. The patient may suffer generalized malabsorption, so that high concentrations of solute, for example, glucose, remain in the lumen. So in case of severe malabsorption, some substances patients eat, for example glucose, stay in intestine and cause actually osmotic diarrhea. Sometimes patient has a specific absorptive defect. Now, for example, glucose galactose malabsorption. Glucose galactose malabsorption. You know, some people they can't drink milk because after drinking milk they experience diarrhea. Why? They can't absorb galactose. In this case, it may cause osmotic diarrhea too. How to detect? No, diarrhea stops when patients stop eating or some substance which causes this diarrhea. Stop drinking milk and diarrhea disappear. Secretory diarrhea. In this disorder, there is both active interstitial secretion of fluid and electrolytes as well as decreased absorption. Common cause of secretory diarrhea are enterotoxins, for example, cholera. You know cholera. Why people die from cholera? They die due to severe dehydration. Patient with cholera can lose up to 10 liters of water. If it's not feces, it's just rice water as we referred, because it's just pale water. Due to increased permeability of intestinal wall due to toxins, due to enterotoxins. Bile salts. In some cases, again, don't forget bile salts absorbed at terminal ileum. If we have ileal resection, bile salts enter actually large bowel, increasing reabsorption, increasing actually passage of water into the lumen of the large bowel due to, again, increased secretion. As a result, we have diarrhea. No, the same for fatty acids and some laxatives. Some laxatives also can cause secretory diarrhea. Inflammatory diarrhea. Inflammatory diarrhea occurs because of damage to the interstitial mucosa cell, so that there is a loss of fluid and blood. In addition, there is a defect absorption of fluid and electrolytes. No, common causes are infective conditions, for example, Shigella, and inflammatory conditions, for example, ulcerative colitis and Crohn's disease. Abnormal motility, diabetic, post-vagotomy, hyperthyroid diarrhea are all due to abnormal motility of the upper gut. In many of these cases, the volume and weight of stool is not all that high, but frequency of defecations occurs, and there is no due diarrhea. Again, in case of hyperproduction of thyroid hormones, nothing wrong with actually intestine. All problems due to the fact that contractions increase. We talk about nervousness of intestine. The intestine becomes nervous. As a result, propulsion increases, and this is not true diarrhea. Acute diarrhea. Diarrhea of sudden onset is very common, often short-lived and requires no investigation or treatment. This type of diarrhea is seen after dietary indiscretions, but diarrhea due to viral agents also lasts 24-48 hours. Traveler's diarrhea, which affects people traveling outside their own countries, particularly to developing countries, usually take 2 to 5 days. Usually due to microbes. Clinical features associated with acute diarrhea include fever, abnormal pain, vomiting. If the diarrhea is particularly severe, dehydration can be a problem. The very young and very old are at risk, special risk from this, and investigations are necessary if diarrhea has lasted more than 1 week. Usually it lasts only a few days and disappears even without treatment. Diarrhea in patients with HIV infection. Chronic diarrhea, common symptom of HIV infection, but HIV's role in the pathogenesis of diarrhea is unclear. Cryptosporidium is the pathogen most commonly isolated. Isosporia belli and microsporia have also been found. You know that in HIV infections, different germs may be found everywhere, and these germs may cause diarrhea in case of damage of intestine. Now let's talk about inflammatory bowel disease, disorders which usually presented as disorders of intestinal damage. So inflammatory bowel disease. There are 2 major forms of non-specific inflammatory bowel disease are recognized. This is Crohn's disease, which can affect any part of the GI tract, gastrointestinal tract, and ulcerative colitis, which affects only the large bowel. And there is overlap between these two conditions in their clinical features and histological and radiological abnormalities, and in 10% of cases of colitis, a definitive diagnosis of either colitis or Crohn's disease is not possible. No, it's possible that there is conditions to represent two aspects of the same disease. So, what we know now, two disorders, Crohn's disease, ulcerative colitis. Again, this is inflammatory disease which affects gastrointestinal system. Differences following. Ulcerative colitis affects only colon. Crohn's disease may affect colon, but may affect all GI tubes starting from esophagus. Esophagus, stomach, small intestine, large intestine. And again, they're so similar that sometimes it's difficult to understand what is it, ulcerative colitis or Crohn's disease. So, Crohn's disease. Incidence of Crohn's disease is rising, varies from country to country, approximately 5-6 per 100 population annually, prevalence 27, 106 per 100,000 population. Not so common disease. Incidence of ulcerative colitis stable, 6-15 per 100 annually, prevalence 80, 150 per 100,000. No, you see, not very common disorders. Not very common disorders. Etiology is unknown, but racial difference, geographical clustering suggest both genetic and environmental causes. We have some genetic and environmental predisposition. Crohn's disease. Crohn's disease is a chronic inflammatory condition that may affect any part of the gastrointestinal tract from the mouth to the anus at the tail, but has a particular tendency to affect the terminal ileum and ascending colon. Ileocolonic disease. The disease can involve one small area of the gut, such as terminal ileum, or multiple areas with relatively more normal bowel between so-called skip lesions, or it may also involve the whole of the colon, total colitis, sometimes without small bowel involvement. Ulcerative colitis can affect the rectum alone. Proctitis can extend proximally to involve the sigmoid and descending colon, left side colitis, or may involve the whole colon. In this case, we talk about total colitis. Clinical features of Crohn's disease. Major symptoms: diarrhea, abdominal pain, weight loss. Again, diarrhea, abdominal pain, weight loss. Constitutional symptoms of malaise, lethargy, anorexia, nausea, vomiting. Low-grade fever may be present, and in 15% of these patients are no gastrointestinal symptoms. You see, sometimes we have disease without gastrointestinal symptoms. Despite the recurrent nature of these conditions, many patients remain well and have an almost normal lifestyle. However, patients with extensive disease often have frequent recurrences necessitating multiple hospital admissions. Clinical features are very variable and depend partly on the region of the bowel that is affected. Disease may present insidiously or acutely. Abdominal pain can be colicky, suggesting obstruction, but it usually has no special characteristic, and sometimes in colonic disease only minimal discomfort is present. Diarrhea is present in 80% of all cases, and in colonic disease it usually contains blood, making it difficult to differentiate from ulcerative colitis. Steatorrhea can be present in small bowel disease. Examinations. Physical signs are few apart from loss of weight and general ill health. Aphthous, ulceration of the mouth, is often seen due to vitamin deficiencies. Abdominal examination often normal, also tense and tenderness and right iliac fossa mass occasionally found. The mass is due to either to inflamed loops of bowel that are matched together or to an abscess. Barium flow through examination should always be performed in patients suspected to have Crohn's disease. The findings include asymmetric alterations of mucosal pattern with deep ulcerations, areas of narrowing, of stricturing. Also commonly confirmed to the terminal ileum. Confined to the terminal ileum are the areas of the small bowel can be involved, and skip lesions with normal bowel are seen between affected sites. Now again, pictures. You see terminal ileum, and you can see different lesions. Different lesions. This is ulcerations, the arrow, so-called typical ulcerations, cobblestoning. Cobblestoning. You see like a stones inside. Cobblestoning in terminal ileum. This is typical picture of ulcerated Crohn disease. Crohn disease. Now this is picture of actually investigation used by endoscopy. You see like cobblestone appearance, the cobblestone appearance, like stones, like lumen of intestine or surface of intestine covered with stones, the cobblestones picture. Ulcerative colitis. Major symptom in ulcerative colitis, diarrhea with blood and mucus, sometimes accompanied by lower abdominal discomfort. Now, general features include malaise, lethargy, anorexia. Afterwards, ulceration in the mouth is seen. The disease can be mild, moderate, or severe, and in most patients runs a course of remissions and exacerbations. Again, as all other chronic disorders. All chronic disorders, they may be in phase of remission when patient feels himself better, or signs absence, or exacerbations when all signs becomes advanced. 10% of patients have persistent chronic symptoms, while some patients may have only a single attack. It depends. It depends. When the disease is confined to the rectum, proctitis, blood mixed with the stool, urgency, tenesmus are common. There are normally very few constitutional symptoms, but patients are nevertheless greatly inconvenienced by the frequency of defecations. In an acute attack of ulcerative colitis, patients have bloody diarrhea passing up to 10-20 liquid stools per day. Diarrhea also occurs at night with urgencies and incontinence that is severely disabling for the patient. Occasionally blood and mucus and alone are passed. You know, just imagine patients who should visit toilet 20 times per day. Of course, this is a severe disabling of the patient, and I remember even young patients with ulcerative colitis, so they should fasting for 1 or 2 days to be able to leave actually their home, because after fasting, no feces, no defecations. No, this is very inconvenient, of course. It's extremely inconvenient. Imaging, how to investigate and detect actually ulcerative colitis. A plain abdominal X-ray with abdominal ultrasound and the key investigations in moderate to severe attacks. The extent to disease can be judged by the air distribution in the colon, and the presence of colonic dilatation can be noted. Thickening of the colonic wall can be detected on ultrasound, as can the presence of free liquids within the abdominal cavity, and instant prepared barium enema is a good investigation to show extent of disease. Findings may include a superficial ulceration and shortened and narrow colon in long-standing disease. So what we are talking about? We're talking about that ulceration can sometimes lead to perforation, and of course in this case we can find signs of peritonitis, fluid in abdominal cavity. In other cases we just can't find signs of large bowel damage. Usually this is ulceration, ulcerative colitis, the big ulcers, big ulcers. Now again, few pictures. You see in ulcerative colitis, you see how one of the features that gaustrations disappear. You see, normally large bowel should have gaustrations, gaustra pattern. Here you see that large bowel look like as a tube, as a pipe. The tubular featureless colon with fine ulceration. So like pipes, becomes like a pipes. Colonoscopy Should not be performed in severe attacks of disease for fear of perforation. In more long-standing and chronic disease, is useful in defining extended activity of disease. And in patients with total ulcerative colitis of 10 years duration or more, colonoscopy and multiple biopsies should be performed to exclude dysplasia and carcinoma. Dysplasia and carcinoma. So again, two very serious disorders, Crohn's disease and ulcerative colitis. Now it's possible to treat using specific expensive remedies, monoclonal antibodies to stop this autoimmune process. No, this is a separate story, how to treat such patients with such serious disorders. Okay, that's all for today. If you have questions, please, you may write your questions, type your questions in the chat, and I'm waiting for your questions few minutes. If everything clear, please write that everything is clear to be sure that you are responding, that you hear me. Okay, waiting for your questions. If everything clear, just type, just write, everything is clear. Okay, any questions? Okay, if no questions, good luck. See you next lecture.